Rafael, clearly there's a lot of guidance out there to try to help with giving guidance, and you do tend to agree with Elias that there's really nothing standard about AML therapy, and that it really needs people who have a strong focus. In terms of guidelines, any of those that you have found that are helpful that you see folks are using in the community?
In terms of AML therapy?
In terms of prophylaxis, so
I see.
in terms of infection prevention, dealing with neutropenic fever, NCCN guidelines, other things, things that you've seen that folks have found helpful?
I think the NCCN guidelines are a great example of where actually putting on paper a standard treatment regimen is helpful, so that groups that don't have as much experience can actually rely on the experience of others to help. But to Elias's point, I think as good as the individual physician may be, the real important thing is to have the entire treatment team have experience with treating these disorders, having the ER know to start antibiotics on time, having the nurses know how to recognize patients who might be ill and need more attention. That all comes into play. But things like, I think that you mentioned, the NCCN guidelines are useful. The IDSA also has guidelines about the treatment of neutropenic fever and when to add certain antibiotics, and when not to overtreat, when not to use MRSA treatment, for example, for prolonged periods of time and so on.
Sure. So as we think about kind of specific agents on kind of the preventive setting, is there a typical recipe that your institutions would use in terms of a particular azole for prevention or antibiotic or antiviral? Does everyone get one of each in terms of a triple therapy?
Well, the policy at our institution, we use quinolones for bacterial. We give the valsaclovir for covering viral, and then azoles essentially, because azoles are oral to be given. Otherwise, you have to give them IVs, come back to the ATC, it's complicated. With the choice of azoles, posaconazole has a preventive labeling, which is the isacofanazole, the new one they don't have so far. But we are having phase 2 studies assessing these drugs. But one should keep in mind that there's absorption problem. You have to check for the level, and then the copay. When I write prescription for my pharmacist writes prescription, patient will call me, my copay is $500 per month or $1,000. Then fluconazole, yes. I mean, by default, I have to give him something. So that is still not so easy. At NDSM, my pharmacist, as Rafael mentioned, we have a team. So a pharmacist will call social worker, case manager, get some help, and call the pharma to see what we can help our patients. But still a struggle. And if they don't have covered or home care or something, they have to come back to the hospital. We have moved them to IV drugs like caspofungin or the liposomal formulation of Enbizome and others.
Yeah, no, I think as you say, I mean, we have a strong armamentarium. I mean, that posaconazole preventative data was very strong, but clearly things need to be individualized as well. I mean, patients are on complex, regimens, and clearly coverage remains a complex issue. I certainly hope for my patients it simplifies over time. It's very disappointing that when we clearly have effective therapies, preventions, antifungals, or other options that were limited in that way.
I think to your point also, it's like sometimes the toxicity profile for those medications or the course can dictate some of them. For example, in our institution, the first few days when the patients are on anthracycline regimen, they start with micafungin to avoid the interaction. Once they finish the third day, then they will shift to azole. Posaconazole may have less transaminitis than voriconazole. So the toxicity you see also, and where are you in the regimen in transplant, obviously when patients are on immunosuppressants, there is so many interactions that sometimes dictates the choice. But I think the data on prevention are clear that posaconazole and voriconazole are better than fluconazole for sure.
Now, what about length of therapy? If someone is on a preventive medicine or preventive antifungal, how long would you keep that therapy on board?
Partly depends on what's coming next in that patient's future. So if a patient really is headed to transplant, we know that they're going to get to a point where they're going to be immunocompromised severely, even if they're not at the very moment. So we typically continue the prophylaxis through that experience. In general, if you have a patient who maybe is just going to get high-dose ARC consolidation and they're done with that process, recovery of counts is a good point to assess where they're at.
Yeah, it's very tricky. I mean, it's certainly as I try to think about people recovering, I think the kind of immune system recovering is really a slow process. as well as a recovery of all the kind of subtle injuries they really received through the therapy, the mucositis and things of that nature. I agree with you as well, particularly with antifungals. It tends to be a much more longer course, particularly since there's usually something on the other end. As opposed to it being kind of the final cycles of consolidation, it's kind of usually something on the other end. In particular, if they've had an infection, we're continuing to try to suppress it. In my area, we as well have a lot of COXI and other factors that we clearly have to be mindful of.
I want to add among the azoles choice as well could be what you're doing. For example, if I'm giving clofazimine for AML induction, I have liver dysfunction. Or in ALL, if I'm giving like the new monoclonal antibodies, inotuzumab ozogamicin can cause liver dysfunction, I may be limited with the azole choice I have. QT prolongation, other factors, some of them cause QT prolongation, some of them don't cause QT prolongation. So beyond the label of preventive or not, you may make different choices based on what you're doing for a specific patient.
I think as we look at individualized medicine, I think that part too will evolve. I think we'll have a better sense of predisposition to infection. I think there's a greater assessment of the microbiome and other factors, as well as probably a much better understanding around the metabolism of some of these agents on an individual level. Because again, I think with dosing and some of these drug interactions, it's a little bit of still uniform dosing, but I think we'll certainly have some refinement.
Right. I think one thing also we didn't touch on is basically the challenge in diagnosing invasive fungal infection. Most of the time, actually, we treat for a presumptive infection because in the setting of AML, to do bronchoscopy sometimes if not feasible, imaging, patients are immunocompromised, they have neutropenia, they may not have the classical features. So I think it's a key to recognize that those patients are at high risk of fungal infections, and sometimes it's absolutely okay to treat as a presumptive infection without an absolute evidence of infection, because sometimes it's difficult to do that.
And I think you raise an excellent point that, really prevention is so key in this setting that I think as I still look at the arc of AML as a whole, many of these patients still really will rely on an allotransplant as a key part of their salvage or cure. And that, nothing can really derail that process more effectively than an invasive fungal infection that has not responded or is progressing. That patients really lose the opportunity for some of those options or the option of going on a trial or other things because they have a very severe infection. So really nipping those things in the bud are really essential, because otherwise then we just have the mortality not only from the disease but really from the infectious causes that are related. So clearly it takes a village. It really takes a team. I think you'd mentioned before, even the aggressive approach of some baseline scanning, I think, is prudent, particularly with people with a complicated course. And I'd say also, pulmonologists, sometimes dermatologists in terms of cutaneous infections, other things can be clearly helpful. Now, shifting gears back again, we had been taking the deeper dive regarding the azoles and their potential role both in prophylaxis and treatment. And as we know, there's 4 azoles at the moment. There's fluconazole, there's voriconazole, there's posaconazole, and there's isovuconazole. Now, Rafa, as we're thinking between these, what are the different things you're thinking about as you're utilizing an azole in terms of optimizing the care?
So I think about the coverage that each one of them has. So fluconazole, very good against Candida species and things like that, but not so effective against the molds. And we talked about how that's important in preventing infections in patients in particular who are at very high risk of these infections. So that influences my decision. The toxicity of the medications, what liver function, what organ functions they affect is also going to be a key component. Does the patient have hepatic compromise, or are they likely to, based on the treatments that we're giving? And then finally, what are the drug-drug interactions that are going to influence my decision? So for example, you mentioned patients on clofazimine where you expect hepatic toxicity. You might want to avoid voriconazole where it's known to cause a greater degree of transaminitis and use an alternative agent. And patients who may have QT prolongation as a known consequence of one of the azole treatments, especially if given in combination with another drug that can do that as well, you may want to take that into account. So those are the features that we consider when we think about which drug to use. But in actuality, we rely on the judgment and interactions with our ID colleagues who have a tremendous amount of experience with these agents, and together we come up with a plan.
Sure.
You know, I think
All right.
more options we have, better is the outcome. So at least we can personalize, even in antifungal therapy, as Rafael mentioned, somebody who cannot take oral medicine, what do you do? Somebody who's on specific chemotherapy, what do you do? Somebody who has QT already prolonged, what do you do? So at least with the plethora of agents we have today, we can select which one is the best. And again, we rely on our colleagues' recommendation to what best for the patient.
Sure. No. As well as being guided by the evidence as best we can. I know, from my end, I really view that kind of prevention role as very slightly different from where we have an active infection where we've been guided and such. Certainly was very impressed by the 2007 New England Journal article. The role of posaconazole compared to fluke and Vori was very strong. So I think all things being equal, I certainly consider that a strong option. But we need to weigh all of these different components as part of that.